Welcome, practicing clinicians. My name is Joshua Tavaletti, and today I'm here to discuss transference in clinical psychology. Transference is one of the most enduring concepts in psychology, after being introduced by Freud in the early 1900s. And although interpretations do vary, it can be defined as the patient's feelings and beliefs towards the therapist as a result of their own past experiences. Transference can take many different forms. A patient might develop unconscious competitiveness towards the therapist, idolize them as a parental figure, or even develop romantic feelings towards them, all a result of their past encounters. Although transference does occur in everyday relationships, it takes on particular significance in therapy, where unconscious material, like relational patterns, come into light. These projections can often stir emotional reactions in the therapist, what is called countertransference. Countertransference refers to the therapist's emotional reactions, both conscious and unconscious, shaped by their own history and the client's affect towards them. Historically, countertransference was seen as a hindrance to therapy, something to be mastered or even suppressed. The concern being that it may cause disrupted perceptions, leading to misattunement, boundary issues, and a weakened therapeutic alliance. However, contemporary theorists like Melanie Klein view this relational dynamic differently. Instead of something to be avoided, it can serve as a valuable source for clinical insight. And so, working with transference requires awareness of the unconscious interplay between patient and clinician to reduce its effects on the therapeutic outcome and become a tool for understanding rather than interference. This leads us to our creative and evidence-based solution, which is mindfulness and meditation, specifically when practiced by the clinician themselves. Broadly, mindfulness can be defined as the moment-to-moment awareness of one's own experiences without judgment. And applied to a clinical practice, this means approaching each session with presence in an open and discerning way. Through regular mindfulness practices like meditation, a therapist begins to cultivate awareness of their own inner world, including the unconscious material that might otherwise influence their responses towards a patient. This present moment awareness creates space between emotional arousal and the therapeutic responses, helping a clinician regulate their internal triggers whilst remaining attuned to the client's needs. And research does support this, finding that psychotherapists who engage in long-term mindfulness practices are better equipped to distinguish between their own experiences and that of their patients, which is a trademark of transference dynamics. David and Hayes conducted a qualitative study that explored how meditation, self-differentiation, and mindfulness were effective as countertransference management. And they found that mindfulness was predictive of non-reactivity, which allowed the clinicians to stay grounded and less emotionally reactive. And other research also supports this, proposing that in this way, mindfulness affords clinicians the capability of observing transference and countertransference dynamics as they arise and using them as a tool for insight rather than becoming entangled in them. We can see how a mindfulness approach complements psychodynamic models like object relations theory, which was proposed by Kernberg. And this emphasizes how our early relationships shape our inner representations of self and others. And these dynamics often emerge in therapy as transference and countertransference. This is built upon by transference-focused therapy, which builds on object relation theory and helps to identify object relation patterns and has shown statistical significance in reducing symptoms of borderline personality disorder patients. TFT focuses on the here and now relationship between the therapist and the patient, which mirrors the attentional stance cultivated through mindfulness practices. Mindfulness isn't just a wellness add-on, it's a practical tool for clinical insight. And by staying present, the clinician can manage these dynamics and their own reactions to help foster effective outcomes for the patient. So, how does mindfulness apply to the world of a clinical psychologist? Well, employing these techniques does require diligence and commitment. But in the world of a clinical psychologist, you will inevitably encounter these unconscious dynamics. And so these techniques may prove vital for the effectiveness of psychotherapeutic outcomes. So let's look at some practical ways to use mindfulness in your practice. Pre-session grounding. Begin each day or each session with brief mindfulness check-ins to regulate your nervous system and to clear any lingering material from past sessions or even your own life. These grounding practices help support the present moment awareness, which is useful to dealing with transference, especially in highly emotional interactions with patients. Post-session reflection is another technique. At the end of each day or at the end of each session, you could engage in deeper meditative reflection to help integrate the experiences and emotions from the day and help identify any emerging relational patterns throughout your therapeutic relationships. An alternative could be journaling, which is a good way to externalize your internal experiences. The key here is to turn the unconscious material into conscious awareness, where it reduces the risk of becoming maladaptive and leads to things like misattunement and ruptures in therapy. Although mindfulness may be a valid approach, there are obvious barriers to overcome. Time constraints are an issue for any professional in high demand. And so, by integrating brief mindfulness practices into existing routines, like between sessions, you can overcome this barrier without the additional time. Emotional discomfort may emerge from reflective practices, and for this, it is advised that clinicians use clinical supervision and seek out support services to help them discuss the experiences between them and their patients. Skepticism is another obstacle, with some deeming mindfulness as being too spiritual, but it should be reframed as a clinically supported tool for insight, regulation, and the therapeutic presence. Transference and countertransference are inevitable in psychological work. If left unexamined, it can significantly distort the outcomes of psychotherapy. And by adopting a mindful approach, a clinical psychologist can develop the self-awareness needed to manage these dynamics. I hope this presentation has shone a light on the underlying dynamics that clinicians experience in psychotherapy, and maybe you've seen these tools as being relevant to your own practice and you adopt it in future sessions. My name is Joshua Tavaletti. Thank you for your time.